Hello and welcome to the Alabama Public Health Training Network. I'm Kay Melnick, Chief Nursing Officer at the Alabama Department of Public Health. Thank you for joining us today for our program, Bronchopulmonary Dysplasia, Nobody Puts Baby in the Corner. At the completion of this program, participants should have a better understanding of bronchopulmonary dysplasia, its evolution over the past 20 years, risk factors, comorbidities, and guidelines for outpatient management, including routine counseling for patients and families. Today's program is produced and provided by the Alabama Department of Public Health. This program is also supported in part by the UAB Pediatric Pulmonary Center grant from the Health Resources and Services Administration of the U.S. Department of Health. The contents are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. There is no commercial support or sponsorship for the program. There will be no endorsement of products displayed in conjunction with this activity. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handout, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. No partial credit will be awarded. While content may continue to be relevant, CE credit will only be awarded for 2 years expiring on April 20th, 2025. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our faculty presenters today. Dr. Christopher Miles Fowler, Assistant Professor in the Division of Pediatric Pulmonary and Sleep Medicine at the University of Alabama at Birmingham. Joining Dr. Fowler, we have Ms. LaJasmine Gary, a mother of twins with bronchopulmonary dysplasia. Welcome. I know you both have a lot of important information to gather today, so let's go ahead and get started.
Thank you. I'm Miles Fowler. I'm a doctor at the Children's Hospital of Alabama and UAB. I have the pleasure of being one of the 3 providers who works in our bronchopulmonary dysplasia program, and I'd like to talk to you all about BPD today. So just an overview of what we're going to be talking about. We're going to talk about what is BPD and how has that changed over time. We're going to talk about what are some risk factors that might lead a baby to have BPD and what are we doing to try to prevent that. We're going to talk about some of the other health problems that can happen in children who have BPD. And we're going to talk about how the outcomes of how healthy are these babies and what happens to them over time has been changing in the last few decades. And then we're going to look at some of the latest guidelines that have been published both here and abroad for, how should we be taking care of these babies once they leave the hospital. And then I'll be talking about one of my favorite things, and that's our clinic, our program, and who we are and what we do, and some of the people that we have the pleasure to take care of. And then we'll get a chance to talk to Mrs. Gary about her experience and her beautiful babies. So this might be the driest part. What is BPD? So back in the 60s, when babies were born premature, they would have hyaline membrane disease, and that's basically when you don't have that pulmonary surfactant to help you open up your lungs and breathe easy. So the first descriptions of this premature lung disease were related to that. And then over the passage of time, they started to add things to this idea of what is this dysplasia. So they added this idea that if you've been on oxygen for more than 28 days, you probably have this disease. And then a while later they said, well, let's not just talk about those first 28 days, but what about by the time you should be more mature? Around 36 weeks is getting pretty close to, you know, the time when your body should be able to breathe on its own. So if a baby's still needing oxygen at this 36 weeks, they probably have some degree of lung disease. And then after they added those little tweaks, there have been a lot of different authors publishing a lot of different studies saying, oh, well, maybe we could break it down into what is a mild amount of disease, what's a moderate amount of disease, or a severe amount of disease based on what amount of support the child is needing. And then as recently as 2019, there was a study that attempted to describe or compare these different definitions and look at, okay, if we use this definition versus this definition with these different criteria, you know, can we come out with a definition that's going to help us predict which babies are going to need the most help or who's going to be the sickest and have the most problems, and we need to keep a close eye on them. Here is a table. I apologize. It's very small. I don't know if it's easy to read or not, but that's on me. This is from Up to Date, but it's basically a description of how the definition has changed over time, and if you want to read these different definitions or these different studies that have been published, you can see who wrote them and what were they working on and how did they describe BPD. And then the most recent that I told you about, this Jensen paper, this is a comparison of the different definitions of BPD based on, you know, how much oxygen are you on? Is it more than 2 liters? Is it more than a certain percentage of oxygen? Is it 100% oxygen? Is it 21%, you know, what we call room air? And then, you know, is this child getting pressure? You know, are they on a non-invasive pressure support system like a CPAP or something like that, or are they on an actual ventilator? And then, you know, comparing all these different things side by side, it looks like the best definition, you know, if we're using the percentage of oxygen and the amount of invasive or non-invasive support, you can come up with a definition that lets you know, well, these are the babies that are going to have the most trouble. So I say all this just to say our definition of BPD is changing with time, and it will probably continue to change because we're not always talking about the exact same disease when we're describing children who need oxygen, you know, at birth or at 36 weeks or whenever. You know, there's a whole lot of different problems that could kind of add up together to contribute to this that might all get labeled with the same diagnosis of BPD. And there are other terms that you can use that are kind of similar to BPD, like chronic lung disease of prematurity or premature lung disease. So you might hear a whole bunch of different terms to describe the same disease, or one blanket term that describes several diseases. So this can be confusing, and that's why I want to spend a little bit of time talking about the definition. But if we're trying to figure out, you know, okay, if this is what the disease is, what makes us end up having these problems? And there's a couple different things. So some of these things are things that happen before we're born. Some of these are problems that the babies encounter after they're born. And all these things can kind of add up. So this is a nice table that this is from another paper that's going to be referenced there at the bottom and then at the end. But the basic idea is there are certain babies who might have genetic changes and they're predisposed to have this problem. There might be environmental factors that lead to prematurity and premature lung disease, like infections that happen before you're born, exposure to smoke, things like that. The basic idea is all these things might lead to chronic inflammation even in utero. And then when we're looking at the postnatal risk factors, it's a similar idea. There are things that we do to help take care of these children that also cause them inflammation, like receiving oxygen. It causes inflammation. Being on a ventilator causes inflammation. Having infections after you've been born, which is fairly common to experience a neonatal septic event. All these things can contribute to inflammation that can lead to what BPD is, which is lungs not developing as you'd expect them to. And not just the lungs, but all the tissues that support the gas exchange. So we're talking about, if we're getting into nitty gritty, the little bitty cells in the alveoli that trade the gases back and forth, your oxygen and your carbon dioxide, but also all the blood vessels that take up that oxygen or release that carbon dioxide. Everything is affected, every part of the lung tissue. And all of that tissue is immature, not fully developed, or dysplastic. So that's why we're calling it BPD. Here's some of the things, but not all of the things that can happen in babies who are experiencing BPD. All of these things have pretty close association. So not everybody, but some of the children with BPD also have kind of asthma-like symptoms or obstructive lung disease. Some of them will have some restrictive components depending on what else is going on, or some fixed lung disease is another way to describe that. It's not uncommon if you're born premature to have immature airways. So just like the way I talk about it to parents is when you're playing with the little bitty baby ear right after they're born and you're just kind of folding it. It's always fun at first that it kind of slowly creeps back into place. So all that ear is cartilage. And when you're born early, that cartilage is softer and less mature. Your airways are made out of similar cartilage. So if you can imagine the ear being a little extra flappy, you can imagine your airway is a little extra flappy. And the fancy doctor word for that's malacia. So a lot of these babies will have airway malacia, whether it's up around the voice box or lower down in the trachea, or even the further branches of the lungs, of the airway. Another problem that's pretty common to see is a lot of these babies will need respiratory support in the form of a ventilator, so it's not uncommon to experience complications of being intubated for a long time. And that can be something like subglottic stenosis that you see on the list, which is a narrowing of the upper airway right below your voice box, just from having an endotracheal tube right in that position. And you can, of course, have some vocal cord issues with that too. One of the common and most concerning things that can happen in babies who have BPD is pulmonary hypertension, with or without any kind of cardiac lesion. And we take that seriously because babies who have this pulmonary hypertension are at risk for having a pulmonary hypertensive crisis or getting very sick very fast and needing extra medicine and extra breathing support. And then further down the line, once these babies are able to eat, it can be a little bit more difficult for them. Since they were born early, they weren't born ready to eat, and it might take them a little extra time to catch up, learn how to do that. They tend to have some reflux, and some of them are at risk for aspirating. Not every baby aspirates, but some of them do. And to one degree or another, some of these babies have had a neurologic injury. That might have been a hypoxic event at birth, or just what you call an intraventricular hemorrhage when they were born. And neurologically, they might have had an injury, and it might be more difficult for them to learn how to eat, or they might have some degree of dysphagia that leads a little bit of that milk when they try eating to go down the wrong way, get in the windpipe, and then work its way down the lungs and cause a whole lot of inflammation and make that BPD a little bit worse. The outcomes of BPD. So this is where we're putting baby in the corner. This is the punchline to the joke, and I don't know if it's going to pay off or not, but on the left is old BPD, and there's Jennifer Grey and Patrick Swayze in their moment of triumph in Dirty Dancing. So old BPD is this idea. Decades back, we used to take care of these babies different when they were in the neonatal ICU. So we used to use higher ventilator settings, higher pressures, higher volumes if you're in a volume control. We used to have different goals for how to help them with their breathing. So we were trying to make the carbon dioxide levels more normal, or as close to normal as we could get, and keep those oxygen levels very high. And that just meant you had to use higher settings on the ventilator machines. And all that led to using more oxygen, more pressure, more inflammation in the lung, worse BPD. Babies born decades ago would have fibrosis or other kinds of lung diseases pretty bad, and hard to get better with time. New BPD is a little bit different. I have never seen Havana Nights, but this is the new version of Dirty Dancing until 2026 is what IMDb says. So new BPD is less fibrosis, so less scarring, and more just immaturity. Things, we're born early, things weren't done cooking, so to speak, or things weren't they didn't reach their full development. So that's including the airways, the alveoli where the gas exchange happens, but also all that vascular, like I mentioned before, all the blood vessels that are supposed to bring blood to and from the lungs are also not mature. The reason that we've seen this change from old to new BPD is that things have changed in the last few decades in how we're supporting these infants. And a neonatal physician might be able to speak more to this, but basically there are new modes of ventilation. We have more non-invasive options for helping babies breathe, like CPAP and things like that. That means we're using less pressure, less volume. We're being a little bit more gentle on these lungs. We're allowing the babies to have a little bit more carbon dioxide in their bodies than what we used to, and not necessarily aiming for them to have a oxygen saturation of 100% all the time. We're tolerating a little bit lower amounts of oxygen. And, there's research happening all around the country every day, all around the world really, about, what are the absolute best kind of parameters that we can set to minimize the damage that we do to these lungs as they grow. So that's still in progress, but every day we're learning, better ways to take care of these children. So every day the outcomes are going to be getting better, especially looking into the future and babies that are born today, how they're going to look 10, 20 years from now. Okay, bringing up the part of how do we prevent BPD? There's all kinds of studies that have been published for decades and decades, and we haven't found a lot of things that really we know help. There's some things that may help, and there's literature on both sides. So if I say something helps or something doesn't help, if you do your own research, you're gonna find papers that say this thing's great, and then you're gonna find papers that say, I don't know about this. This might not work as well as we think. But caffeine is one of the things we think might help. There's debate about it, but it may help prevent BPD. Like I talked about, trying to use more non-invasive forms of respiratory support, lower settings, and then time and growth. And there might be some things that we can do nutritionally that helps prevent BPD, but there's some back and forth in the literature on that. And there's some things that we've tried that most people seem to agree haven't helped as much as we hoped. Surfactant, like I mentioned at the start of the talk, is important. We need surfactant to be able to open our airways, open our lungs up, and be able to take those breaths. And surfactant, you can give artificial surfactant or animal surfactant to a baby who's born too early, and that helps with their respiratory distress in that early period, but it doesn't prevent them from getting BPD down the road. There are lots of other medicines that we've tried, like diuretics or things to treat pulmonary hypertension, nitric oxide, all kinds of things. And those are great treatments, and they help babies with what's going on in that moment, but they don't keep the babies from developing bronchopulmonary dysplasia. But I'm not saying that any of these things are the wrong thing to do for any child, because they help with other problems. They just don't prevent the disease. And we'll get into some more talk about that. So, most of what I do is not necessarily in the neonatal intensive care unit. My favorite place to be is in the clinic and in our bronchopulmonary dysplasia clinic. So outpatient management is really where my expertise is. And I think this is when I wanted to spend most of my time being able to share what I know with y'all. And so this slide, I'm not sure how easy or difficult it is to read, but I'll try to walk kind of through these guidelines. So on the left side, there's the guidelines published by the American Thoracic Society. And then on the right side is similar guidelines published in Europe and both of these guidelines are about taking care of babies once they're out of the hospital. And on the far left are potential interventions that we can try to help them. And then kind of a comparison of what we do here versus what they do across the ocean. So things like albuterol. I'm a lung doctor. I take care of tons of babies with and children with asthma, so it's very easy to prescribe, and I'm used to prescribing it, and I want it to help everybody. And the guidelines say basically you can try it and it may work or it may not, but it's worth trying, and some families find it helpful, especially, and I think the Europeans kind of emphasize this in their guidelines, if you have a child who has asthma-like symptoms, whether it's coughing, wheezing, working hard to breathe, albuterol might be able to help with that. And if you try it and it helps, great. And if you try it and the family tells you, well, we couldn't really tell much difference, well, then you know, okay, maybe for this baby, albuterol is not going to be as helpful as we wished it was. Another thing that pulmonologists in general like to try is steroids. So again, similar thoughts on both sides of the ocean, and there's little differences between inhaled and systemic steroids. Systemic steroids may be helpful in the outpatient setting. Inhaled steroids possibly, but maybe a little bit less likely to be helpful. The Europeans are not really, they don't seem to use as many steroids as we do, and they have a little bit more doubt about how helpful that can be. And then when it comes to oxygen, I think we have similar philosophies of it can be helpful in the short term, but we'd like to try to wean it eventually. And I think the families agree they don't want to be on this oxygen for very long. So when it comes to managing oxygen as an outpatient, there's all kinds of strategies. It really is different. You can't say that everybody in America follows this ATS guideline, or that everybody in Europe does the same thing either. When you look at the published literature about how people are practicing, it's very widely variable. But the basic idea is if you have a baby on a certain amount of oxygen, it might be a good idea to try to either wean the volume or the flow that you're giving them with time, or the other approach is, well, maybe we could wean, not the flow, leave that alone, but maybe try to get them off in terms of how many hours a day they're using it. So while they're awake, well, let's take a little break for an hour or two, and then try to lengthen that until we're off during the daytime. And then once you've got to a point where you're not using much oxygen during the day, then you might be able to talk about a plan for getting them off the oxygen at night. And then the American or the ATS guidelines have this idea that when you get to the point where you're thinking about no longer supporting or using oxygen for sleep or at night, then it might be a good idea to either think about getting an overnight oximetry test just to see, recording what the oxygen saturations are throughout the night. Do the numbers look good? Is this baby keeping their saturations in a healthy place, or are they having a lot of dips? And then I think a little bit lower in the table we talk about, is there a role for sleep studies? So after oxygen is diuretics. So I think kind of the guidelines are very similar in that diuretics don't seem to be very helpful in the outpatient setting, so we try to wean them as quickly as we can. And there's different strategies to do that as well. I think the Europeans recommend letting the babies grow, and as they grow, the dose of their diuretic over time becomes less and less effective until eventually they outgrow the dose entirely, and then they just discontinue it. And then we have a similar idea. And then sleep studies, once again going back to this when they're using the oxygen daytime, nighttime, if you have a baby that's not just on oxygen at night and healthy and growing and doing fine, but if you have a child that is using oxygen at night but they have some kind of respiratory symptoms at night, maybe they're having long pauses while they're asleep, or they're snoring, or something that makes you think there might be a component of sleep apnea in addition to this chronic hypoxic respiratory failure that they've been experiencing since birth. This is a baby who, instead of doing just an overnight pulse ox recording, maybe you really want to get more information, and you want to get that information using a sleep study. So there's probably cases where this is more helpful than the overnight oximetry when you're trying to make this decision about is the baby ready or not to come off this oxygen. One of the next things on there is swallow evaluations. I think the European guidelines didn't say much about this, but having difficulties with feeding is one of those comorbidities that we know is associated with BPD. And if you have a baby that has symptoms of aspiration, whether that's coughing when we take our bottles, or gagging or choking, or sometimes folks will notice, oh, my baby sounds more congested after or during or after, right after a feed. Those are all things that tell us, ooh, okay, maybe this is this could be an aspiration situation. And if, especially when a baby's having a hard time growing, they might be failure to thrive, or they might have their growth velocity might have slowed down and they're not following that curve like they were before, even after maybe they never even got on the curve. They left the NICU and then their growth kind of plateaued or kind of flatlined. Then you might say, oh, okay, this is a baby who we might need to take a closer look at their ability to swallow. Or if they're having persistent respiratory symptoms, you know, their baby's coughing at night most of the night, or getting sick a lot, bronchitis all the time, things like that. You say, oh, okay, if we're always sick and we're never well, is it because every time we're eating there's a little bit of something going down the wrong way, stirring things up, making us unhealthy? And then there's some description of bronchoscopy. I can't say that we do this a lot in our practice, but there may be a role for it in similar situations where you have a baby who's not growing well, or maybe more so if you have a baby that's has a lot of upper airway noise, and you know that they were intubated for a prolonged period, and you kind of suspect, oh, maybe they could have some complications of that prolonged intubation. Maybe they do have a subglottic stenosis. Maybe they have a web or a cyst or some kind of scar from having a tube in their airway for so long. Or they're having a hard time growing, or persistent respiratory symptoms, or recurrent pneumonias, or things like that. So there may be a role for this in certain cases. And then antibiotics, the guidelines are pretty short. If you have aspiration pneumonia, great. Otherwise, they don't do a whole lot for these babies. And then imaging, the Europeans kind of suggest getting serial images over time to see how the lungs progress. The ATS guidelines didn't really touch that. Our practice tends to be we get an x-ray with the first visit after you've left the hospital, and we may have other images we can compare that to depending on what system they were born into, and do we share images with that system. So that can be helpful. And there's kind of this debate of, oh, okay, well, do we need to keep doing that, or is one enough and you leave it alone? But essentially, if you're doing great, no worries. We don't necessarily have to keep getting pictures every time you come to the hospital, but if you have a baby that's not getting better with time or having other complications, maybe it would be a good idea to get another x-ray and see, is there something else going on outside of just the normal BPD that might be giving this baby, making problems where this baby's not progressing as you'd expect, because this should be a problem that always gets better with time. And then lung function, as mentioned in the European guidelines, it's always hard to do lung function, even in big kids. You know, I also take care of children with asthma, you know, of all ages, and it's really hard for people to do PFTs. I've tried doing a PFT, and it is not easy. It maybe took me 3 tries to do it correct with the right technique. If you can imagine, it's nearly impossible to get a baby to do that. You have to do special things like use sedation and have special devices to do an infant PFT. So it's not really a viable option in infancy, but as they get bigger and older and more mature and they're able to follow instructions, you might be able to do lung function in the future. In our particular case, the babies that we are taking care of currently, a lot of them have outgrown their respiratory issues before they're old enough to do pulmonary function testing. So you're going to find different practices in different places regarding lung function testing. And then I think the last thing that it talks about in the guidelines is infection control. That's always challenging. There are different ideas about trying to prevent recurrent viral infections, and how can we help these babies get through the winters, or get through that transition from a pretty controlled environment in an ICU to at home where you're surrounded by other people and usually lots of other children who like to bring their colds and things to the baby and give them kisses and love on them. The Europeans specifically mentioned talking to families about daycare. That's not something that's in the ATS guidelines, but it is something that I know physicians here talk about. Everybody worries about daycare and going to daycare and picking up germs and things like that, but that's really it's a challenging topic, because you don't want to tell a family like, hey, you can never put your child in daycare, because everybody's social situation is different, and that is probably not an option for a lot of the people that we're taking care of. And I don't think it's fair to everybody to kind of give them a blanket statement of, this is or this is not what you should do for taking care of your children. Okay, well, we're getting close to the halfway mark, so you're probably getting tired of me talking about my stuff, but the funnest part of our talk, we're getting close. So this is a picture of our team. I think my tummy was full because we had just eaten dinner in this photograph, and I don't think I'm smiling. I might be uncomfortable because I ate too much. But this is a picture of most of our team. I'm sorry to the team members who were not here on this occasion. I don't know. I don't think I have a laser. Maybe I do have. Oh, no, I switched the slides. Okay, so starting on the left, if we're looking at the back row, that's Dr. Turner, and then beside him is Lashana, who's our respiratory therapist, and then I see Trinity, who's one of our awesome nurses, and Kelsey, and then there's Miss Daphne Arnold, who's our new social worker, and there's me making a grumpy face, and then on the front row is Miss Catherine, who's a new addition to our team recently. We're very excited about her. A nurse practitioner, and then there's Macy beside her, who's another one of our awesome nurses, and Miss Michelle too. And then I always tell this to the families, but in that bottom right corner is the most important person on the team, and that's Brittany. She's our dietitian, and she helps fatten up these babies to help them grow and make those lungs bigger so these babies can breathe easier. So that's most of our team, but there's a few other folks too. And then the other half of our team is the families. So we take care of, in this BPD program, who we're seeing is our little bitty babies who go home with either oxygen or a tracheostomy, with or without oxygen, but not a ventilator. We have a separate program for children who go home with ventilators. And then, if you don't go home with oxygen, if you do go home with a diuretic, whether that's Diaril or hydrochlorothiazide or Lasix, or I'd even include maybe some, if you're on a anti-pulmonary hypertensive medication like sildenafil or something like that, we'd be likely to see you. Or in certain situations, if you have a twin or a triplet, quadruplet, whatnot, if one of the babies went home with oxygen and the others did not, well, we like to see them all. I imagine it's hard to go someplace without taking everybody with you. So, and it's not uncommon for if one of the babies is having issues around feeding or anything like that, that is also something the other babies may be experiencing. So, I feel like it's helpful to the family sometimes to see all the babies together, even if not all the babies are having respiratory issues or they're not all on oxygen. And this is a list of some of the things we do. But I know just based on looking at my team members here that they'll tell me, oh no, I do 500 things that I can add to this list, and there's no way I can fit it all onto a slide. But we meet babies while they're still in the neonatal ICU, so we help the teams in the ICU know, like, hey, is this baby getting ready to go home? What are some things we could do to help them get ready? Is there any advice we could give them for the transition, or anything that we could add to their care to help kind of bridge that gap between when they leave the hospital and then when they get to our clinic, so they stay healthy and don't end up back in the hospital if we can avoid it. And then, like I mentioned, Miss Brittany Belcher, so probably one of the most important things we do is help these babies grow. And there's a lot of different things that we do to accomplish that goal. It can be as simple as, hey, maybe we're on a kind of formula that's got 20 kcals per ounce or something like that. Maybe we need to concentrate that formula a little bit to add a few extra calories. Or maybe switch their formula from one formula to another for whatever reason, whether they're having symptoms with this one and we want to see if we can help some of those tummy symptoms if we switch to another formula, or maybe they've reached the age where, hey, this formula is no longer developmentally appropriate. Maybe we need to switch to Pediasure or Cape Farms or something like that once they get to being about a year old. A big part of what we do is teaching families. So when we're talking about feeding, we're asking the families, how long does it take for your baby to get through this bottle? Because if they're feeding, more than 20, 30 minutes, that's a lot of work to get a little bit of calories in you, and that might tell you, oh, okay, this baby's struggling. Or asking them about, educating the families about the symptoms that they might be aspirating, because a lot of folks don't know, and for a lot of families, this might be their first child, and once we tell them, hey, if your baby's coughing, choking, gagging, this is not a normal baby thing to do. So maybe we need to look closer into this and figure out, is there a problem with milk going down the wrong way? And and then, maybe helping them, give them instructions for how to make that formula thicker if we need to. We do a lot of counseling, whether that's about sleep is one of the big issues that we talk about. Smoking cessation is probably one of me and Dr. Turner's favorite things to talk about. I think we spend a lot of time, we here in Alabama, around our region, I think we have a higher percentage of families who smoke than maybe other parts of the country. So, and it's not uncommon for me to meet a parent and say, hey, have you, do you smoke? And did you quit while, if it's mom, were you able to quit while you were pregnant? And a lot of moms will tell me, yes, I quit when I was pregnant, got these babies home, and now I'm stressed, and I went back to smoking. Or, same things that happen to dads. Dads will quit. Or, whatever the circumstances may be, working with them to see where are you at? Are you interested in quitting again? Do you want to talk about it? And then if they are interested, here's some resources that we could give you. And we'll be your cheerleaders. And I'm going to ask you next time you come to my clinic, have you made any progress or not? And, having that conversation I feel like is very rewarding. There's a lot of things that Ms. Dabney, I think, would tell you she could add to that list of social support. I only put a fraction of them on there, but, a lot of these families are navigating services, like applying for SSI, or, somebody might have mentioned it, that in all likelihood, a bunch of people told them in the hospital, hey, you got to do this early intervention thing. And they're just overwhelmed by so much. Once they get out of the hospital, they might forget. And then we bring it up, and they're like, I never heard of that. So talking to them about early intervention, reminding them what it is and how they get into it, and so their babies can get therapies that they may need to help meet their milestones. And then respiratory care. I am a lung doctor. I'm a pulmonologist, so I do a lot of lung care. But in the BPD clinic, I might do more of this other stuff than lung care. But teaching families how to recognize when their baby's working hard to breathe, which for a lot of them, they know because they were there in the ICU when their baby was on a ventilator, and they know what retractions look like. They know what working hard to breathe looks like. But for some, you need to help the parents understand, like, hey, these are signs that your baby might be sick today, or there might be something extra going on that we need to pay attention to. And then, helping families know when is it time to stop oxygen, when is it time to stop their medicines, because all the things that we're asking these families to do are very difficult. And I think it would be very easy as a caregiver, when a baby's pulling their oxygen off, to just say, I give up. Like, I don't want to do this. I don't want to fight this battle every day, instead of just tucking it back in the nose. So talking to families about the reasons why we're doing these things, and giving them advice about, how to make it as easy as possible, while helping them understand, like, it's very hard, and we don't expect anybody to be perfect. Just try to be encouraging for them, tell them, just do your best and get through today, and it won't be forever. And then, being a resource, not just for the families, but I think for some of the other providers around the state. We get a lot of calls from NICUs all around Alabama asking for advice, and me and the whole team, I think we're always happy to help. And I have talked way too much. Here is, if you need it, this might be helpful. If you're working in an outpatient primary care setting, these are the requirements for Synagis in the state of Alabama. If you have BPD, you're younger than 12 months, you can get Synagis your first year of life. And then if you're past that first year, you have to have used like oxygen or inhaler or a diuretic within 6 months of the RSV season, which usually starts in October. So for all these patients, these are patients that could potentially get Synagis through their primary care provider. And of course, we're always happy to help if you have questions about, hey, I'm taking care of this baby, do you think they could get Synagis? You can look it up yourself, or you can call me and I can help walk you through it. We can help you figure it out. And okay, now I think we got to the best part. Okay. Well, give Mrs. Gary a chance to tell us about herself and her experiences and her beautiful babies and what it's like to be on the other side of the conversation.
Okay, so you're looking at MJ, Pierre, and Mila Parker. They were born at 24 weeks, due in February and born in October. So we spent almost 5 months at the NICU here at Baptist East. And I thought NICU was rough, but the post-NICU journey, I think it's rougher. just a lot of appointments, getting ready to be discharged. We did have a discharge nurse who gave us all the discharge appointments, and one of them was BPD. Was kind of nervous because I got a whole book and a link to watch a YouTube video. And it's like, you got to watch this video. So it's like, oh my God, what is BPD clinic? Like, kind of overwhelming. And MJ actually got to go home a little bit before Mila. So his appointment was first. So like you mentioned earlier, it's hard. So of course, trying to find somebody to watch Mila while we took MJ to his first BPD appointment. But when I got there, it was great. We, live in Montgomery, so we had to drive to Children's. And it's kind of hard because, you drive like an hour and a half and get there, and sometimes you're there for like 30 minutes and it's time to go home. But not with the BPD clinic. That's an all-day journey, but it was a good journey. MJ also had another appointment that afternoon, but he got his x-ray, and then getting to meet the providers, and it was great because it's really a team, and that's, for me, has been the most helpful part of navigating this whole post-NICU journey is the team. Getting to meet the social worker. I am a social worker myself, but I haven't had to deal in this area. So knowing those resources, I wasn't familiar with them. We did already have the early intervention set up from NICU, but there were some additional resources that I did learn about from the social worker in the BPD clinic. Dietitian, they were 1 pound 7 and 1 pound 11 ounces. So, of course, grew some in the NICU, but we still had some growth to go. Having the aspiration, so the swallow studies. So it has been a journey, but definitely good one and scary because Mila did have to end up with a G-tube, and I found that out through the swallow study and the dietitian in the clinic. So having Dr. Turner be able to walk us through that, and we made sure we scheduled her surgery when he was going to be there. So having him and the team, so it's been really great. And like I said, the biggest thing is having the team because, although it is an all-day thing, it's worth it. Getting to talk to the different providers and getting different information from each provider has been really good.
Thank you. Yeah. I appreciate that. I'm not Dr. Turner, I'm the other one. So, I bet you got a million nice things to say about Dr. Turner. And I agree, he's great. So he trained me, and most of what I do is almost exactly what he does. And I think probably the most important thing that I learned from him was when he walked in the room, he talked to the family, say, "I'm not the most important person that you're going to see today, and this first visit is very long, and I'm just a tiny part of it. But you're going to see Miss Daphne, you're going to see Brittany, you're going to see everybody, and everybody has something to contribute."
Exactly.
And sometimes when you just see one person, and we ask you a question, we might get one response, and then you see another person, and they might ask you a similar question. You'll have more time to think about it.
Exactly.
Other things might come to your mind.
Yes.
I can't tell you how many times I've talked to one of our nurses have gone and said, "Oh, we're not having any issues with feeding. Oh, feed's fine. Yeah, my baby eats. We're good." And then Brittany or me or somebody else will come in, or even the respiratory therapist sometimes, because I feel like it's such a big team. Sometimes families don't know who's who. You just don't. You shoot your questions at everybody because you don't know who's the person who's going to help you. But so many times people will say, "Oh, well, after so and so, I thought about it, and yes, we are having this issue with feeding."
Oh, I forgot that part. Good question.
Yes.
I didn't think about that.
Yes. So I think that's helpful. Having this big team gives people more chances to think about these things, ask these questions, and get help that they need. I wanted to ask you, just so people can understand a little bit about your experience. Can you tell me what your NICU experience was like before you left the hospital? Kind of some of the things that that your girls had to go through before they were able to go home.
So we started out with an oscillator. Never heard of an oscillator. Didn't know what an oscillator was. But basically, them being there and the machine pretty much doing the breathing for them. And of course, we became very close with the respiratory therapists in the NICU. And one thing about the therapists, as well as the nurses and, the provider, is celebrating those milestones. So when we got to go to the next form of equipment, we said, oh, we graduated from oscillator, awesome. And then having twins, it was kind of like highs and lows, because MJ, he may do better than Mila, and they were really in competition the whole time. So she may do better once on something and get off of something first, and then he's like, no, I'm going to catch up, and he'll get off. But then she ended up getting sick, and her having to go back, and the nursing staff explaining why this equipment was better than this particular equipment, because of course, once you've graduated from something, you don't want to go back to it. But I oscillator, CPAP, just having room air, so of course that's the goal. Let's get to room air. We don't want to be on oxygen. And then so I know one of the nurses would tell them, it's fun to breathe on your own. And that, that kind of stuck with me, and I would tell them too, it's fun to breathe on your own. So the goal was, let's get to room air. But, just understanding more of the equipment and the purposes. Like I said, celebrating those milestones and getting to graduate. Oh, we're not on oscillator anymore. Oh, we're not on CPAP anymore. So what's next? Which one do we get? So just knowing, and as we graduated from different things, we were getting closer and closer to the door. The goal, of course, is to get out the door and get home. But yeah, so that was, definitely a learning experience. Learning the beeps and what the beeps mean. What this a good beep, or no, that's not a good one. Like, hey, help. But it was definitely challenging. But like I said, overall, we had a great support staff. Really, celebrated. They got there in October. They were born on the 21st. So we celebrated all the holidays in the NICU. All of them. It's a lot of holidays between October and March. So, and the nurses were great. They create so of course they had little turkeys, and they were little pumpkins with their names on them. And so. That
was my next question is, did they dress them up like turkeys?
Yes. So for Halloween, they were Mickey and Minnie Mouse. And of course, that was one of the kind of challenging things, because I don't know if everybody's seen a baby that early, but at 24 weeks, you don't really look like a baby. So helping me to kind of normalize and treat them more like a baby, because it's like, you don't really look like one. So they definitely did, the Halloween costumes. Of course, they couldn't put them on clothes because, we were in the oscillator. So they had like a little paper outfit that they kind of placed on them to be Mickey and Minnie, and, took pictures. So that was great. But yeah, we got to do all the great holiday things there.
And then when y'all got out of the hospital, what were the things that you were having to do that you would consider kind of extra?
Medications, that was the biggest thing. Like you spoke, the diuretics. So we had diarrhea, 2 puffs a day with their little spacer. And of course, at that time, they were used to it. Now, if they get sick and I have to put them on the little machine, it's a challenge. I think I get more albuterol in my face sometimes. Yeah. But yeah, definitely. And then trying to stay on schedule, because some of the medicines were 3 times a day versus 2 times a day. And which one's morning, which one's afternoon. And the pharmacists in the NICU did a pretty good job of labeling my syringes. Like, okay, this syringe is for this. So I know, okay, this one gets, and then MJ's a little bit bigger than Mila. So some of his doses were a little higher. So trying to, okay, this one's MJ's. And of course, it's hard to get anybody to watch. It's hard to get people to watch. Of course, when they came home, they weren't newborns, but they were still newborns. So it's kind of challenging to get someone to watch your newborn baby. But then when your newborn baby comes with a whole bag of medication, it's really like overwhelming. So I am fortunate. I did have one of my aunts that was a nurse, former NICU nurse, so she was able to kind of help. She was able to keep them some time, so that was a plus. And still talking to the NICU staff, like, hey, I got a question.
Yeah.
So still being able to reach out to them. They were a great support system. And then even with the BPD clinic, and of course, you know, trying to juggle the regular twin life, plus I have other kids and wife, and you know, going back to work, so it can be challenging. But one thing, being able to send an email, so hey, got a quick question about something. If it was something that took a little bit longer to answer, give me a call, you know, when you can. So that was good, not having to wait to our next clinic appointment to be able to get those questions answered. Because yeah, definitely the medication challenges and knowing when, but I was glad, hey, we graduated from diarrhea. Like, oh, MJ graduated first because he's the bigger one. So he got to come off of it before Mila did, but finally, and then, you know, oh, we don't have to do the puffs anymore. So it's like, great. And then, like you said, with the Synergist, so we get Synergist shots, and those shots are once a month. I think we go like half a year.
Yes.
Yeah. So, but we can't get Synergist if we're sick. So we have a Synergist appointment scheduled. Oh, wait, one of them's sick. And of course, with them being twins, we want to keep them on the same schedule. So Mila's sick this week. So no, we have to reschedule that appointment. But we need a sick visit. So it's like we're going to the pediatrician for a sick visit. And then, okay, we'll see you next week for the Synergist. Oh, no, MJ's sick. Oh, so now we're pushing Synergist back another week. But I know the importance of it. They both did end up getting RSV. Actually, MJ more so than Mila. And they, thank God, it was actually right at the beginning of RSV season. So it was like September going into October. Because I know it got hit really bad. Alabama got hit this year. So we got in and out the hospital before the hospitals, you know, really got flooded. But of course, that wasn't fun, you know, being put back on oxygen. MJ actually had to take an ambulance ride. Which our doctor's office is right next door to the hospital, but just because he needed that oxygen, the pediatrician felt safer to put him on the ambulance. And I'm thankful for our pediatrician and our team because they're on the safe side. Like, I'd rather be safe than sorry. And listen to me like, this doesn't sound right, or they're not looking right. Go ahead and bring them in. Like, let's look at them. And then having the additional support. We have other providers at Children's as well. So definitely. And then the providers being able to coordinate with one another. So I love that you guys do that. So it's like, hey, I see that you just, you know, saw Dr. Turner in the BPD clinic or Dr. Fowler, and, you know, now we're in GI clinic, and I see that they said this and this. So great that they have that team collaboration even across providers and across clinics.
Thank you. I want to ask you if we still, I think we still have a little time. I want to give you a chance to talk about, you mentioned getting RSV and going through that with both of them. And you don't necessarily have to speak about that time, but any time that your children have had respiratory illness, RSV, cold, whatever it was, kind of walk me through, like, what's that like, you know, what you felt like worked for your girls and what didn't work, and you know, how you dealt with it, like, or who helped you with that treatment plan of, okay, I know what to do on a normal day, I got this inhaler, I got my albuterol or whatever, and then, you know, what to do on a sick days and what that's like at home.
Sometimes it's, okay, I know what to do. Sometimes it's not so sure. Let me ask a question. And we just started daycare 3 weeks ago. So before daycare, I was grateful that my cousins were able to watch them. But they have 3 girls who are in school. So, you know, they have germs. I have kids that are in school. They have germs. So, you know, they were still getting germs from the outside. For the most part, they're pretty sheltered. Anytime we go somewhere, they get sick. So anytime we went to a family dinner or anything, they get sick. And sometimes it's really like your typical baby getting sick. Sometimes it's a little bit. And I know MJ, well, like 2 months ago, I think we went to the doctor and he had to get hospitalized again, and it was kind of like kind of scary and then even with me, I told him sometimes I feel like every time I go to the hospital somebody's having to be put inpatient. And so it's like, oh, praying, Lord, please let us go back home today. So sometimes it's easy, normal stuff. They both got COVID, which thank God that was like a breeze. Really didn't notice anything different, so which was scary because COVID, premature babies, PBD, all the other stuff they have going on. But we got through COVID with no problem. Got through RSV with just a short hospital stay. We've had strep. We've had a little bit of everything. And then adding the medications back to it. So on antibiotic, on albuterol or buprenorphine, something with a B. So another steroid. So no, we're going to do, and then alternate. So, okay, give me that again. Like you want me to do which one at what shot? Okay, rewind that. And so, but I will say the staff is pretty patient. Cause I'm like, wait, what? So I'm like, because in my head it's just overwhelming. Like, okay, I'm doing albuterol 4 times a day, and I'm doing this other one 4 times a day, but they're not overlapping. So how am I going to get both of these medications into their body and not overlap? And then of course we gotta sleep.
Yeah, and go to work.
And just
eat
do life
at some point.
And I have other kids.
Yes.
So
Help them with homework.
Yes, trying to juggle everything. So it's constantly like praying, don't get sick. But they're sick now. MJ has some kind of GI virus, something, and Mila has some kind of other virus, and then they swap. So like she'll have one this week, and she'll get better, and she'll get what he had, and he'll get what she had, and yeah, so it's like share, but don't share your germs. And of course, they're babies, and it's kind of hard to keep them apart. And then sometimes, like something will show up on one before it shows up on the other. Like MJ, the COVID showed up on him first before it showed up on her. So it's like, well, I know you're not going to be able to keep them apart, but Mom, try to keep them apart. Really? Like, please tell me how that's going to work.
I don't know.
So I mean, sometimes it's unrealistic. Like, it's just not going to work.
Yes.
And then advocating for them and me, like, it's not going to work. I know we had with Mila going to daycare, and the daycare is like, not with the G-tube. So talking to one dietitian like, hey, I need a plan. Like, what are we going to do? Oh, well, 13 hours on the pump. Wait, what? Like, put her on the pump at 6 and take her off at 7. It's not going to work. Like, most of the time I'm probably not home by 6, and then I still gotta get her ready for bed. I still gotta do this, and then at 7 I'm trying to walk out the door, not take her off a pump. So reached out to Brittany like, hey, give me another plan because this was not working.
Yes. Figuring something out that actually works in real life.
Yes, and so it's like, okay, let's try this, and tried that. Brittany, that's not working either. She's like, okay, let's try this, and so just having that support.
Yes. Oh, I'm sorry. We could go all day, I bet.
Thank you both so much, Dr. Fowler and Mrs. Gary, for that wonderful presentation. It's great to see it from a clinical perspective and then the personal perspective from a parent's view. So we have some time for any questions that have been submitted. So if you have questions, now is a good time to email them to adph@adph.state.al.us. And I think we have already had one question sent in.
We have a few, really. So this kind of goes along with what you all were talking about with bringing the babies to the hospital, kind of from both of your all's perspectives, both the lived experience and maybe expectations. But in the first, let's say, year or so after, say, discharge from the NICU, or maybe even into the second year of life, has been your lived experience of how many times you've been coming into clinic outside of maybe the hospitalizations, and then what would be the expectation for number of visits, like routine type visits outside of maybe sick visits for a child? Because we're talking about a big burden on families.
Yes.
Montgomery's relatively close compared to some corners of the state, and it's still quite a drive. So kind of reality versus,
And I think about that, like you said, because when we're driving, like just imagine if I lived in Mobile or like way North Alabama, and it's been some days like, hey, we get to Birmingham quick. Other days it's raining, it's an accident. Oh, here's another accident. So we typically go every 3 months. Yeah. And then one thing I do like is the schedulers are pretty good if we do have other appointments, getting them scheduled together. So say, hey, let's come in. And then, of course, with our swallow studies, getting the swallow studies scheduled around the same time as the clinic appointments. So we typically every 3 months for BPD and about 6 months, 3 to 6 months for our swallow studies.
And if I was paying enough attention, did I hear that y'all have been back to the hospital, like had to stay overnight twice now, or?
Oh, good question. I think Mila's been three, 4 times. MJ's, no, I lose count. I think MJ's been three times. Yeah, something like that. Yeah. And that's just in the past year. Because they were in April, so they came home March of last year.
Okay. Yes, I'd say from the other side of the table, the first visit we like to, between leaving the neonatal ICU and first coming to clinic, we like to get you in less than 2 months, if it's possible. Hopefully, the sooner the better. We did do, what we call a quality improvement project, or trying to see what can we do to make things better, help these babies out. And we saw that the earlier we could see them after leaving the hospital, the less likely they were to get readmitted to the hospital, have to go back to the neonatal ICU. So that's one thing we've tried to change, is make our clinic more available, especially for this first visit when babies are transitioned from hospital to home care. And then after that first visit, we usually like to see a baby within 6 weeks if we can make that happen, because, that's when, the parents have really taken charge of this baby and they're doing most of the feeding. And if we're having those early issues with growth or feeding or whatever, if we can get you in sooner rather than later, we can change something if we need to. If we're not reaching those growth goals, or parents are starting to notice issues, like after we've had a conversation about what things to look for, oh yeah, I am seeing some of this coughing or gagging or choking, or it's taking us we were doing fine at first, but now we're starting to show some signs of maybe aversion even, because we've been aspirating for a little bit. So we try to get those babies a very quick follow-up so we can keep a close eye on that growing. And then after that, it really depends on the situation of the parent and the baby, but if things are going great, we're meeting our growth goals and not having a whole lot of respiratory issues, we might be able to go every 3 months. Or if we still haven't met those growth goals, or we've got this persistent cough that won't go away, or we've been back to the hospital and we seem to have a hard time staying well, we might need to see those babies sooner rather than later. And as far as like how many times a child might have to end up in the hospital, that's it's different for every baby. There's a lot of factors that go into that, like did they have any comorbidities? Did they have any surgeries that need to happen in the future? Like, do they have to end up getting a G-tube? Or do they need a hernia repair or a circumcision or a heart surgery or things like that? And, maybe the more comorbidities you have, you might have pulmonary hypertension, you might be at risk for, RSV or COVID might be real mild in one baby, but then maybe not so much in another child. So we have some babies, thank goodness, maybe don't have to go back to the hospital ever again, but I think your experience is not uncommon in that a lot of parents, babies get sick, it happens, no matter what you do, if you're doing everything right, on all the best medicines in the world, and we know, after talking about the guidelines, we know we have these things, but they're not all perfect. Babies do get sick and they have to go back to the hospital sometimes, through no fault of anybody. So, Yes, I hope that answered the question.
So as a segue from that, someone wrote in asking to know more about treatment advances.
Yes, well, there's all kinds of research. I think there's a whole lot of research aimed at, how do we prevent BPD, and a whole lot of research done in the NICU, by these excellent physicians who are taking care of these hospitalized infants all around, our state and, everywhere. The outpatient world, I think there's less research, and I think there's a lot of opportunities there to learn about how to take care of these babies. There's a network kind of dedicated to the outpatient management of these babies that's growing, that's performing research, trying to figure out the best ways to, or how to answer some of these questions that we have about how can we keep these babies sick, how can we prevent them from getting sick, when they do get sick, what's going to work to help them out. So I'm hoping that we'll have more options in the future, but right now that's kind of in development, I should say. Yeah.
And how much, you mentioned the Jensen paper with the more recent guidelines or classifications of BPD. How much does that guide management in terms of, I know we talk about asthma, say classifications. Asthma is a very different type of disease process, but we kind of guide management sometimes based on classification. How much do the new kind of classifications of BPD guide management, or what you might tell a parent?
Yes.
Or does it? Is it more theoretical?
Well, I think it's a mix. So it's a guideline. So it's saying, hey, here's some things that maybe have some evidence that maybe you can try, and then there's what people have been doing for years in their own clinical practice and their personal experience and their experience with families about what seems to work and what doesn't work. So we always take guidelines into consideration. So I'd say for the most part, in our particular practice, we're kind of doing a mix of, some of the things that are recommended in European guidelines, some of the things that are recommended in American guidelines. I think in our particular case here in the state of Alabama, in the children that we're taking care of, the guidelines say maybe albuterol and steroids don't work that great. I think we have a lot more families who have environmental exposures or are predisposed to asthma or chronic something that's causing some chronic inflammation. And I think we have a little bit more success with inhaled steroids and albuterol and things like that, or even systemic steroids in the children that we're taking care of. So, the Europeans might say, oh, you don't need to do this or that, but we find often that when our babies get sick and the parents are stressed out, because I think this, I heard you say, I hope we don't end up back in the hospital. I think it's traumatic. The neonatal ICU experience is traumatic, and the thought of being readmitted to a hospital is traumatic. So if there's anything that I can do to help prevent that, I may not have a whole lot of evidence for it, but I'll try it because I want the family to have something they can do, and I don't want them to re-experience that trauma if we can avoid it. So we do try a lot of albuterol, we do try a lot of steroids, but for the most part, I think our practice is pretty consistent with the recommendations that are out there, and there's not strong recommendations about much of that. Most of these are kind of like lower evidence recommendations from kind of consensus, but not a whole lot of published data, if that answers the question.
Thank you.
Yeah.
This concludes our program for today. I want to thank both of our presenters for being here, and thank you for watching.